Hello, I'm Lisa, and I'm here to help you review your favorite subject, fluid and electrolytes. Now let's begin with the first topic, fluid volume excess. Now, fluid volume excess is a nursing diagnosis, right? And you know that hypervolemia is the very same thing. Now right away you may automatically think that that means there's too much fluid in the body. And that's true, there is too much fluid in the body. But remember, where does that fluid develop first? When someone is developing fluid volume excess, the fluid is building up first in the vascular space. Now you're going to hear me say vascular space a lot during this review. So make sure that we all understand what a vascular space is. Tell me, what is a vascular space? It's any vessel in the body, the veins, the capillaries, the arteries. Now let me ask, does that include the chambers of the heart? Yes, you know it does. So fluid volume excess is like this. Pretend you have a water hose and you have a sprayer and we've turned it off. And we go over to the water hydrant and we turn it on all the way. Now what is going to happen to the size of the hose? It gets really big, right? Because it's filling up with fluid and the fluid can't escape. Now that is what is happening to all the vessels in fluid volume excess. They are getting really large because they're filling up with fluid. Now the inside of the heart is filling up with fluid as well. Now some of you may be thinking that the fluid was accumulating in the tissue. Well, let me clarify this. They may have accumulation of fluid in the tissue later. But first that fluid is going to build up in the vascular space. Then when the vascular space can't hold any more fluid, leakage occurs. It goes out into the tissue, into the interstitial spaces. Now let's look at some causes. The first one is heart failure. Now when someone is in heart failure, is their heart weak or strong? That's right, it's weak. It's weak, so their cardiac output just went down. If the cardiac output went down, nothing is perfusing well, right? Their heart's not perfusing, their brain's not perfusing, none of the vital organs. But since we're talking about fluid volume excess, I am worried about their decreased kidney perfusion. When cardiac output goes down, what happens to kidney perfusion? It goes down. That's right, it goes down. So what happens to the urinary output? It's going to go down as well. Now think about that. If they're not putting out as much urine as they once did, where's all that fluid staying? In the vascular space. That's right, it's staying in the vascular space, building up. Now take a few seconds and go over that concept with your friend. Okay, let's recap. When someone is in heart failure, is their heart weak or strong? It's weak. So the cardiac output went down. Kidney perfusion went down. Urinary output down. And if they're not putting out the fluid volume, where is that volume going to stay? In the vascular space. Now the next one is renal failure. And this one's easy because the kidneys simply are not working. That's right, they're not working. And when the kidneys stop working, are they putting out anything? No, they're not. So where's all the fluid going to stay? In the vascular space. Now the next three things go together. Alka-Seltzer, Fleet Enema, and an IV fluid with sodium. All three of those have a lot of what? Sodium. And you know that sodium makes you retain what? Water. Where are we going to retain this water? In the vascular space. Now the next thing we're going to talk about is the hormonal regulation of fluid volume. So let's look at some hormones that do regulate fluid volume. And the first one we want to talk about is aldosterone. Now aldosterone, tell me, is it a normal chemical that we have in our body? Yes, it is. It's a steroid, isn't it? In fact, if you want to get real picky, it's a mineral corticoid. Now where in the body is aldosterone found? That's right, it's in the adrenal glands. Now you remember where those adrenals are located? Remember, they're right above the kidneys. That's where they're going to sit, right on top of those kidneys. Now it's very important to understand aldosterone because I think we talk about that throughout this review. Now, let's first look at the normal action of aldosterone. And if you would, read along with me in your book. You see, it says when the blood volume gets low, like with vomiting or hemorrhage, Both will cause a drop in the blood volume. Well, aldosterone secretion is increased, which makes us retain sodium and water. So the blood volume is going to go back up. So let's imagine that we have someone with food poisoning, okay? They have vomiting, diarrhea. You have the picture. Now, what do you think has happened to their vascular volume? That's right, it's decreased. It's a really good thing that we have aldosterone, because what will aldosterone make us retain? You're right, sodium and water. Where are we going to retain this sodium and water? In the vascular space. Now, you can't just say retain fluid with aldosterone, okay? You will miss some questions if you're thinking only fluid. You must remember sodium and water with aldosterone. Now, chemicals in the body, they can get messed up. One day I might produce too much aldosterone, and one day not enough. So see if you can name 2 diseases where the person is making too much aldosterone. Now tell your friend. Cushing's. That's right, Cushing's. Now remember, with Cushing's they have too much of all the steroids, right? Okay, now the second one, it's really hard. Hyperaldosteronism. That's right, hyperaldosteronism, also known as Conn syndrome. C-O-N-N'-S. Now with both, there is too much aldosterone, therefore the client will retain too much what? Sodium and water. And they're going to go into a fluid volume excess. Now, what is the name of the disease where they're not making enough aldosterone? That's right, it's Addison's disease. With this, there is not enough aldosterone. Therefore, the client is losing sodium and water. So they're going to go into a fluid volume deficit. And we'll be talking about that at another time. While we're talking about increased sodium and water, let's talk about one more hormone that controls fluid volume. And it's called atrial natriuretic peptide, or ANP. Now, where is ANP found in the body? The atria of the heart. Now, how does it work? Just remember, it's the opposite of aldosterone. Since aldosterone causes us to retain sodium and water, then that must mean ANP causes the excretion of sodium and water. Now let's talk about that a little more. We all agree that when we have increased sodium and increased water, we have fluid volume excess. That's right. When we have too much fluid in the vascular space, we also have too much fluid in the heart. Remember we said the heart's part of the cardiovascular system. Okay, so now this atrial chambers, they're getting bigger and bigger and bigger, just like the vascular space. Now see, those chambers have to stretch to hold this increased volume. And when the atria stretches, the muscle, the heart muscle, releases ANP in order to fix that fluid volume excess problem. Now how does it fix the problem? Remember I said it's the opposite of aldosterone. And what do we say that aldosterone will do? Causes the retention of sodium and water. So ANP works on the kidneys to excrete sodium and water. Does that decrease the blood volume? Yes, you know it does. Will it fix fluid volume excess? Yes, it will. Okay. Now let's move on to ADH. First of all, what do those letters stand for? Antidiuretic hormone. That's right. So does this chemical normally make you retain or diurese? Retain. Retain what? Water. Water, water, water. That is the key word here. 3 letters with numbers, okay? Now we have 2 ADH problems. Too much or not enough. So let's start with too much. Look at the column on the left of your page, okay? If we have too much ADH, we're going to retain what? Water. So we would go into a fluid volume excess. Now the name of this problem is SIADH, Syndrome of Inappropriate ADH Secretion. Now, an easy way to remember that is too many letters, too much water. Now just listen to me for a second, because this isn't on your handout. Let's imagine that you were asked to drink a gallon of water in 1 hour. Your vascular volume, tell me, will it increase or decrease? That's right, it's going to increase. So see, our kidneys want to help us get rid of any excess fluid. So in this case, you'll have to go take a break, wouldn't you? You're going to have to go to the bathroom to diurese. Do you all agree with that? Well, see, normally when you have fluid volume excess, we're saying urine output goes up. But now think about it. If we have too much ADH, we said we were retaining water. So ask your friend, what is going to happen to the urine output in someone with SIADH? Their urine output will increase or decrease. What do you think? It's going to decrease, and that's weird. That is not supposed to happen, and that's why I'm pointing it out, okay? We just said that when a person goes into fluid volume excess, they have to go to the bathroom. Well, this person is retaining a lot of water, but their urine output is going down. That's right. Will that make their fluid volume excess better or worse? Worse. Now notice, it says on your handout, the words urine and blood. Do you see that? Urine and blood. One of those is going to be concentrated and one is going to be diluted. Tell your friend which is which. The urine will be what? Concentrated. And the blood will be diluted. Now notice on your handout it says concentrated makes numbers go up, diluted makes numbers go down. Now you can only use that rule, concentrated makes numbers go up, diluted makes numbers go down, when you're talking about the client's specific gravity, their sodium, and their hematocrit. Now you just told me that the urine was going to do what? It was going to be what? Concentrated or diluted? Yeah, you said concentrated. So tell your friend why this person is not putting out much urine. They're not putting out much urine because they have too much what? ADH, that's right. And ADH makes them retain what? Water. So tell me, what do you think their urine sodium will be? High or low? What do you think? High, because concentrated makes numbers go up. Okay. Let's say you have a client with SIADH. What would you expect their serum sodium to be? High or low? And remember, serum means blood. Remember, they have a whole bunch of water in their blood. So they're diluted, right? And we just said diluted makes numbers go down. So their serum sodium has to be low because their blood is diluted. Now let me emphasize, if the blood is diluted, that's going to make the numbers go down. And the specific numbers we're talking about are sodium, specific gravity, and hematocrit. Now I know what some of you are thinking. My teacher said that sodium and water follow each other. Remember that? Well, sometimes they do, but not in SIADH. They forget to follow each other in an SIADH problem. Now, let's look at the opposite of this. It's in the next column. If we do not have enough ADH, we're going to do what? We're going to lose water. That's right. We are diuresing large volumes of diluted urine. So if we're losing all of our water, we're going to go into a fluid volume deficit. Could we go into shock? Yes, that's what we are scared of. That's the number one thing we're scared of with this next disease called DI. That's called shock. We're worried about it. DI, what do those letters stand for? Diabetes insipidus. Now tell me, does this type of diabetes have anything to do with blood sugar? Anything at all? No, it has nothing to do with blood sugar. So do not let the NCLEX lady fool you with that, okay? Now you see the letters DI in your book. Beside the letter DI, I want you to write diuresis. Now, circle the letter D in diuresis. Circle the letter D in diabetes insipidus. From this point forward, anytime you see D in DI, I want you to think diuresis. And you'll get more questions right than wrong. And that's the name of this game with the NCLEX, right? Getting more right than wrong. Now, I want you to tell your friend something. Now, if you have a person with DI, tell your friend, would you expect their blood and their urine, what would you expect it to be like? One is going to be concentrated and one's going to be diluted. See if you can figure that out. The urine, diluted. That's right, it's diluted, but their blood is going to be concentrated. Again, just listen for a second because this isn't on the handout. Normally, if we lose a lot of blood volume, our urine output is going to go down. That's right. It's going to go down because we're trying to hold on, retain that fluid. Now, you know when someone goes into shock, you know they don't start diuresing, right? No, they start holding on to what little they have left. Is that happening here in a person with DI? No. And again, that is so weird. That's not supposed to happen. That person is going into shock. But they're still putting out large amounts of diluted urine. That is so strange, okay? They're not supposed to do it. So with DI, the urine is very diluted and the blood is very concentrated. Now tell me, where do you find ADH in the body? In the pituitary. Now where is your pituitary? Do you remember? Point to the pituitary. Yeah, it's somewhere in here, right? Right in here. Now how do people get ADH problems? Well, think about this. It's anything that upsets that pituitary could lead to an ADH problem. Now, you have never heard of someone going to the doctor and saying, look, my ADH is messed up. Please, please do something. No, ADH problems are usually secondary to other problems. So let me give you some key words. They're on your handout. Key words that's going to help you think about ADH problems. Words like craniotomy, head injury, a pituitary tumor, sinus surgery, and here's the biggie, transfenoidal hypophysectomy. Any condition that can lead to an increased ICP could lead to an ADH problem. I want you to put a star by that. If you have an increased ICP, observe for ADH problems. Now, you may see words on the NCLEX you have never heard of before, so let's break this word down, transfenoidal hypophysectomy. See if you can figure out what it means. Trans means to go all the way through something. Sphenoid is sinus. Hypophysis is a fancy word for pituitary. And ectomy, taking something out. So that's a surgery where they're going through the nose to get to the pituitary. Now let's pretend that I have been having very, very bad sinus headaches. And I've gone to my ENT, and the ENT has said, Lisa, we can fix this. Easy surgery, you're home by the afternoon. So I finally agreed to go in and have this surgery, and now I'm waking up. I'm in that outpatient recovery, and I'm looking up at, guess who? You, my brand new nurse. That's right. Now I'm a little groggy. And you know that as soon as I'm able to go to the bathroom and void, I'm going to be able to do what? Go home. That's right. So you help me to the bathroom, and since I'm a nurse, I measure my urine. And I come out and I announce to you I had 3,000 milliliters. Now the NCLEX people are worried about you, right? They are worried and scared of you because you are brand new. And this is why. They're afraid that you're going to look at me and say, oh my goodness, you have some fabulous kidneys. They are working so well. Let's get your things together. You're ready to go home. Here's your instructions for see the doctor in 2 weeks. Take all of your medicine. You pack me up and you wheel me down to the car. Now, bye. See you later. So here I go home. I go home in D-I, add an E to the end of that. That's right. I have gone home to die, right? Because what have I developed? Diabetes insipidus. See, friends are calling and they're asking my husband, how is Lisa? Oh, she's doing really good. She really is. She was very sleepy, so she's in bed and she's really sound asleep. She was cold and I covered her up. She's doing great. Well, he knows nothing about shock, does he? Not at all. So in this situation, would you normally have sent me home? No, of course not, you know. Again, my pituitary will probably kick back in eventually. But in the meantime, could you give me a drug of ADH? You could. Have you ever given DD-AVP? It is given as a nasal spray, and that's ADH. Now, I know that you recognize that urinary output, 3,000 milliliters, was just way too high. See, NCLEX is not going to give you a number that obvious. They're going to give you a number that sounds okay. Makes you think, well, it's not that bad. But with every test question, you must assume the worst. Now, let's look at signs and symptoms of fluid volume excess. I think we all know why the neck veins and the peripheral veins are distended, because the vessels are full. Peripheral edema and third spacing can occur because the vessels, they can't hold anymore, so they're going to start to leak. Now, let's say that you have someone who's on bed rest, and they've been on bed rest for a while. Are they going to have ankle edema? No. Where are they going to have edema? The sacrum. If you have sacral edema, what could their skin begin to do? It's going to start breaking down. Any skin that's edematous is about to break down. Now, what does CVP stand for? Central venous pressure, that's right. Where is it measured? The right atrium. If I'm in a fluid volume excess, is that CVP number going to go up or go down? It's going up. More volume, more pressure. And we're going to say that a lot during this review. If I'm in a fluid volume excess, what are my lungs going to sound like? Wet, that's right. And you may have said something fancy like bibasilar crackles. Well, am I short of breath? Yes. Now let me ask a question. When you people begin to go into fluid volume excess, where are you going to hear those wet sounds first? Up high or down low? Low in the bases, and always posterior. You're never going to have or do a good lung assessment unless you sit them up and listen to their back. Polyuria. Why does polyuria occur? Well, what are the kidneys trying to help me do? That's right, they're trying to help me diurese, trying to get rid of this excess fluid. Now, what is the pulse going to do? Is it going up or going down? Let's get something straight. You know that the heart only wants the fluid to go in what direction? Forward. We don't like backflow in the heart. That is why the heart has valves, to prevent backflow. When someone goes into fluid volume excess, their heart is saying, oh my goodness, where did all this extra fluid come from? And now the heart's having to work really hard, pump hard, work fast, pump faster to make the fluid go forward. See, if it doesn't go forward, it's going to go backward into the lungs. And that's what I'm scared of. I am scared that someone's going to go into heart failure and then pulmonary edema. Now, when you're palpating a pulse, are you palpating a vein or an artery? An artery, because you know veins don't pulsate, right? They just sit there. Now tell your friend how this pulse is going to feel. Other than the word fast, how is it going to feel? Bounding is a good word. Full and bounding. Now when I say a full pulse, what do I mean? Think about it. If someone is in fluid volume excess, what has happened to the size of their artery? It has gotten bigger, hasn't it? It's full. In fluid volume excess, is their blood pressure going to go up or go down? More volume, more pressure. That's right, it's going up. If they're retaining fluid, what is their weight going to do? Go up or go down? It's going up too. Is it going up fast or is it going up slow? It's going fast. Any acute gain or loss isn't fat, it's fluid. Now remember this, fluid retention, think heart problems first. Fluid retention, think heart problems first. Now on your test, you could have a lot of questions concerning teaching. They may want you to teach the client, their family, or even another nurse. Now teach your friend everything they need to know about daily weights. Did you say same time, same scale, same clothes, have them void first? But what if you had an option to say same nurse? Since this is NCLEX, would that be appropriate or inappropriate? Ask your friend. Okay, it's your day off. Are you going to go in and weigh someone on your day off? I don't think so. You would never weigh anyone, would you? No, because you'd have to go in on your day off. It may have sounded right at first. It made you think. See, NCLEX is going to make everything sound good, and the more nervous you get, the better everything sounds. But we're going to overcome that this week. Just give it some time. Now, let's talk about treatment of fluid volume excess. The first thing listed is low sodium diet and restrict fluids. Now, you know, if people have too much sodium, they're going to retain what? They're going to retain more water. Don't forget I&O and daily weights. Now this may be one of those procedures that you could delegate to an unlicensed assistive personnel, right? So remember, you are responsible for teaching them the importance of this procedure because the treatment plan will be based on the results they get. The doctor is going to use diuretics to help them get rid of the fluid. Now, give me an example of a loop diuretic. That's right, Lasix. Bumex may be given when Lasix doesn't work. You also see hydrochlorothiazide, HCTZ. Now, whether the client is on Lasix or HCTZ, what electrolyte are they losing? Potassium. Now, give me an example of a potassium-sparing diuretic. Aldactone. Now, what electrolyte will be retained? Potassium. They're going to save their potassium. So you see, with some diuretics, you would encourage your clients to eat more potassium. And others, you're going to discourage them from eating foods that are high in potassium. It depends on what kind of diuretic they're on. Bed rest. Now, bed rest can be good for this person because bed rest induces diuresis. And you might say, how does that happen? Well, it's with the release of ANP and the decreased production of ADH. Now let's talk about that. When you're on bed rest or supine, your blood volume is going to shift from your lower extremities to your thorax. This increases the volume of blood that's returning to the heart. So what is happening to the atrium? It's stretching. And when the atria stretches, what is it releasing? ANP, atrial natriuretic peptide. And ANP causes you to lose something. What is it? Sodium and water. Also, we have baroreceptors in the aorta, and they recognize this fluid volume excess, and they send a message to the pituitary to decrease the production of ADH. And now we have two processes going on that's causing diuresis. This increase in urinary output and the decrease in blood volume. Now, can that lead to dehydration and fluid volume deficit? Yes. Now, think way back to the first semester of nursing school, when your teachers taught you about the hazards of immobility. Do you remember that scary lecture? Well, the reason people develop problems from immobility, or a lot of them, is because of this diuretic effect that they get on bed rest. You see, when we lose a lot of fluids, our blood, it's going to get thick. Could we develop a DVT? Yes. Could we also develop a kidney stone because are we dehydrated? So yeah, we're prone to now develop a kidney stone. When we lose a lot of fluid, would our pulmonary secretions get thick? So now we might develop pneumonia. It's hard to cough up thick, sticky secretions, isn't it? And if we're dehydrated because of diuresis, what bowel problem might we develop? Constipation. And that is why when you have someone on bed rest, unless it's contraindicated, always push fluids. Okay, back to your handout, and let's look at the physical assessment. Now, in nursing school, you were probably asked to go into the room and do a bio, psychosocial, cultural, spiritual history, and a physical assessment on that client, maybe on the family, the culture, and even the community. You were in that room a long time, weren't you? Do you have time for that anymore? No. It was a very good learning experience. But now you have other people, 5 other people maybe that you're having to take care of. So you don't have time to do that. You need to go into the room and do a focused physical assessment. Now, how do you do that? You must understand the client's signs and symptoms. Now, we just discussed the signs and symptoms of fluid volume excess. So if you have a client who has a diagnosis of fluid volume excess, tell your friend what you would go into the room and assess for the presence or the absence of. Remember, they're listed on your sheet. I'm talking about pertinent signs and symptoms. What you have to do when you go into the room, remember, is a quick head-to-toe assessment. And that is why we're focusing on this, okay? Look at those signs and symptoms that are pertinent. Now tell me, would bowel sounds be pertinent in someone with fluid volume excess? No. Pupils, are they pertinent? No. So if you have a client with fluid volume excess and the doctor has prescribed 40 milligrams of Lasix every morning, a low sodium diet, and bed rest. And you're told in report that the plan of care has been successful. Now, if the plan of care has been successful, what would you expect to find? That CVP, tell me, is it going up or coming down? That's right, it's coming down. What is their blood pressure doing? It's coming down too. And their pulse is coming down. And their weight, it's coming down. What about their lung sounds? Clear. I'm glad you didn't say coming down, okay? We never want the lungs to go down. So, you always have to notice on a test question, are they talking about before treatment or after treatment? And was the plan of care successful or unsuccessful? A good test-taking strategy is listed there in your book. Anytime you see the words assessment or evaluation, think signs and symptoms. And remember, pertinent signs and symptoms are very important on this test. Now, it also talks on your handout about giving IV fluids. And it says to give IV fluids slowly to the elderly. Now, why? That's right. We could throw them into overload very fast, couldn't we? Not only the very old, but also the very young. Now, another group, anyone with a history of heart or kidney problems, they're also at risk for a fluid volume excess. Heart people and kidney people are at risk for fluid volume excess. And that's why on the NCLEX, you want the nurse to do the admission history. Now, if the nurse is an LPN, the RN must sign off with them. See, if you have a new admission, they want you to do the admission history because you can identify the things in the history that you recognize can cause potential problems. Okay, let's imagine that I'm in the hospital and I'm in there with food poisoning. I'm severely, severely dehydrated. Now, you're giving me fluids, right? And you're probably giving them to me pretty quickly. Now, think about it. You're wanting to rehydrate me. Well, you find out that I had glomerulonephritis when I was 14 years old. Now, is this information significant? Yes, you know it is, because now you know I have a history of a kidney problem. So you can't give me fluids as fast as you would normally, right? Yeah. Okay. Now let's talk about fluid volume deficit. And fluid volume deficit is also known as hypovolemia. And anytime someone is in a big time deficit, we call that shock. So this is your shocky page. Okay, let's look at some causes. Notice something. We have lots of causes listed here. And the first one we're going to look at says a loss of fluid from anywhere. Now, everybody understands the kind of blood loss that occurs with surgery or trauma. With surgery or trauma, the blood volume is lost directly from the vascular space. And everybody understands that. But tell me, what if someone has an NG tube connected to suction, and that container continues to fill up over and over and over? Could that person go into shock? Yes, because that person is losing fluid. What if you're assisting a doctor with a procedure like a thoracentesis or a paracentesis? Is that person losing fluid? Yes. Could they go into shock? Yes. What about vomiting and diarrhea? Yes. Okay. Now let's look at other causes. The next one listed is third spacing. And here's my definition of third spacing. It's when fluid is in a place that does you no good. Now, you won't find that in the Tabor's Dictionary. No, you won't. That's a Hearst Review definition. Where do we like our fluid to be? In the vascular space. Well, if we third spaced it, it's not in the vascular space anymore, is it? No. If someone is burned, where does all their fluid go? Into the tissue, into the interstitial space. It's not staying in the vascular space anymore. And that is why a client with burns is so edematous. The next thing is ascites. What is ascites? It's fluid in the abdomen, in the peritoneum. It's not fluid in the stomach. If it were in the stomach, it would blow up. Okay? Your teacher told you that when you have a client with ascites, you must measure something every single day. What is it? Their abdominal girth. When the abdomen is getting bigger and bigger, it's pushing up on something. What is it? the diaphragm, and now they have trouble breathing. That's the nursing thing you have to think about. Don't forget about their breathing trouble. Now, let's think about the client with ascites. The main people I think about here are those with liver disease. Do you agree that those people with liver disease often have ascites? Well, when you look at that person, they have a large abdomen, don't they? That's right. It's getting really large. And sometimes when you turn them from side to side, you may even hear the fluid shifting around in there, okay? Now, to look at that individual, they look like they are in a what? A fluid volume excess. But tell me, is the fluid in the right place? No, it's not. Anytime you see fluid in here, in the abdomen, you better be checking the blood pressure, because could that person become hypotensive? Yes. Now think about it. If they have a lot of fluid in their abdomen, where did all that fluid come from? It didn't just magically appear. It came from the vascular space. So the larger the abdomen gets, their vascular volume is going down. And that's why ascites can be so tricky. Now the next thing on your handout says diseases with polyuria. Now, name one disease that you have studied 10,000 times where one of the major symptoms is polyuria. Diabetes, that's right. So now, let's talk about it. Let's talk about why the diabetic gets polyuria. Let's look at the drawing on the screen. If someone is a diabetic, this is what their vascular space looks like. They have a lot of particles. And since they're a diabetic, what are the particles? Sugar or glucose particles. Anytime there are too many particles in the blood, the kidneys want to help you get rid of the particles. But y'all, have you ever just excreted sugar particles? No. You would have remembered that, wouldn't you? The particles have to come out in volume, and we call that PID. No, it is not pelvic inflammatory disease. It means particle-induced diuresis. Any particle can cause this, but since we're talking about diabetes, we know the particle we're talking about here is glucose. Now tell your friend why the diabetic has polyuria. The kidneys want to help you to get rid of the particles, right? And in the process of losing the glucose, those sugar particles, did they lose volume also? Yes. Now write this down. Polyuria, think shock. Polyuria thinks shock first. Polyuria can cause shock, and that's what I'm worried about. Think about our vascular volume. If you have a person in shock, are they going to continue to put out urine? No, no. Normally when a person goes into shock, their urine output goes down. Okay. So could they go from polyuria to oliguria all the way to anuria? When they start getting oliguric and anuric, what are you worried about? Renal failure? Yes. The key to passing the NCLEX is to understand why, and every function in the body has a purpose. So if you understand why, you can pass the NCLEX, because understanding why improves your critical thinking skills. So now you don't have to memorize anymore because you understand why. Now let's move on and talk about signs and symptoms of fluid volume deficit. And look in your book with me. If I'm in a fluid volume deficit, my weight is going to go down. I have decreased skin turgor, dry mucous membranes, and a decreased urine output. See, my urine output is decreasing for two reasons. My kidneys either aren't being perfused or they're trying to hold on to the fluid, trying to compensate. Now, blood pressure. If I'm in shock, is my blood pressure going to go up or go down? That's right, it's going down. Less volume, less pressure. Now, the client with fluid volume deficit is at high risk for orthostatic hypotension, also called postural hypotension, and it requires some safety precautions. Now, we'll talk about that in just a minute. Is my pulse going to go up or go down? It's going up. The heart is trying to pump what little volume is there and left around. Now, what does this pulse feel like? Weak and thready. Now tell your friend what a thready pulse feels like. Thready means this. When you're in shock, what is the size of your artery? Small like a thread. You see, the pads of your fingers are the most sensitive part of your hand, and when you place the pad of your finger on that tiny little vessel, it's tapping against it. It's going to feel like a thread because that vessel is so small. Now, what about respiratory rate? It's going up. It's going to be increased because, see, the body perceives this decreased blood volume as hypoxia and increases the respiratory rate to improve the hypoxia. CVP, is that number going up or going down? It's going down. Less volume, less pressure. My peripheral veins and my neck veins, they're going to be really, really, really what? Very tiny. Is it easy to start an IV on me? No, not at all. Cool extremities. Now, everyone knows that when someone goes into shock, their skin gets what? Cool and clammy. And everyone knows that. So since we all know that, is it going to be on the test? No, because the things you know well are not going to be on the test. But can you still pass? Yes. Tell your friend why the skin gets cold and clammy. Did your friend say peripheral vasoconstriction? In an effort to shunt blood to the vital organs. Sure, they did. Now, you're in specific gravity. Is that number going to go up or go down? It's going up. If this client has a urine output at all, it is going to be very concentrated. And we said concentrated makes numbers go up. Remember the three numbers we were talking about: sodium, specific gravity, and hematocrit. Concentrated makes numbers go up. Diluted makes numbers go down. Now, let's talk about treatment. First, we want to prevent any further losses. This is very important. We also want to replace volume. So if it's a mild deficit, PO fluids. A severe deficit, IV fluids. And then also safety precautions. Remember, this client is at high risk for falls related to the changes in their vital signs and their mental status. Monitor IV fluid replacement very carefully because we must watch for overload. You see the critical thinking exercise in the box? Let's talk about that. You have an elderly client admitted for dehydration. You are assisting him with ambulation, and your client complains of being dizzy and lightheaded. Are you worried? Yes. What are you worried about? Orthostatic hypotension. You and your friend decide what sequence this assessment should be in. Now, a sequencing question, or better known as a drag and drop question, is just what the name describes. You will be given a list of options, and you will be asked to click on the option and drag it across the page and put it in an ordered sequence. You may be asked to put in order the steps of a catheter insertion, or the sequence of the passage of the fetus during labor. Or you may be asked to rank the acuity of your client assignment. For example, who would you see first, second, and third, and so forth. Any of those subjects, any subjects, can be asked in this way. Okay, let's consider this order. First thing you want to decide is, what is the safest order? Even if you know nothing about orthostatic hypotension, you can think safety and critically think through this sequencing question. You will see these on the NCLEX. Well, if they are dizzy, you want to take their blood pressure in a position that you know is going to be safe, a position that will not allow them to fall. So you lie them down and you take the blood pressure. Now you want to gradually progress them. Sitting is the next safest position. So you can say lying, sitting, and then finally standing. Therefore you have numbers 2, 1, and then 3. Now you know that you are going to record last. So you just need to decide about that 3 minutes. If your client has been standing up and is dizzy, they need to lie supine for at least 3 minutes so their body can adjust to the position. If not, would your findings be accurate? No. So the sequence would be 5, 2, 1, 3, and then 4. Are you going to delegate this procedure to an unlicensed assistive personnel? No. This procedure requires ongoing nursing judgment and assessment and should not be delegated. Now let's turn and talk about IVs, okay? This is your Quickie IV fluid lecture. The first ones listed there are isotonic solutions, and this is how they work. The isotonic solutions go into the vascular space and stay there, and fluid does not move in or out of the cells. In fact, the fluid goes where we put it, and it stays there, and it builds up, and it builds up, and therefore makes the fluid volume go up, making the blood pressure do what? Go up or down? That's right, the blood pressure is going up. Now give me some examples of isotonic solutions. See if you can think of 4. Normal saline, LR, D5NW, and D5 and a fourth normal saline. When I think of isotonic solutions, the first things that come to my mind, the first 2 actually, are normal saline and LR. But remember, D5NW and D5 and a fourth are also isotonic solutions. Now, when would we use an isotonic solution? When might it be prescribed? Well, if the client has lost fluids from nausea, vomiting, burns, sweating, hemorrhage, or trauma. In your book, it also says normal saline is the basic solution when administering blood. Now, when do we need to be worried? What's our alert? Things we need to be cautious of. Do not use isotonic solutions in clients with hypertension, cardiac disease, or renal disease. You see, these solutions can cause the fluid volume excess, hypertension, or even hypernatremia. Now let's say you were to ask to get a bag of normal saline. Tell me, what is the number on the bag of fluid? 0.9. Now let's think about what we're about to do. We're going to be putting 0.9% fluid into the vascular space, right? Now if I could put a number on your body fluid, what would that number be? 0.9%. You see, we're isotonic, aren't we? Yes, because we have fluid in certain places and it stays there. It has a purpose in that place. For example, we have fluid in our brain cells and it's staying there. We have fluid in our liver and it's staying there. Our blood is in our vascular space and it's staying there because we are isotonic. Now, as long as you're putting fluid in the vascular space that is exactly like our own body fluid, we will not see a switching and a swapping of fluid in and out of the vascular space because everything is equal. So when you put isotonic solution in the vascular space, remember, it builds up and the vascular volume is going up. To get a switching and swapping of fluid in and out of the vascular space, you have to put something in the body that is different from our own body fluid, something different from isotonic. That is why we have hypotonic and hypertonic solutions. Different solutions are needed for different problems. If I had to pick my favorite shock solution, I would have to say it's LR, because LR has more electrolytes. Another word they may use for isotonic solution is balanced solutions. Hypotonic solutions. Now read along with me because this also is in your book. Hypotonic solutions, these are solutions that go into the vascular space and then they shift out into the cells to replace cellular fluid. So they will rehydrate, but they do not cause hypertension. These solutions go in, hang out, rehydrate, and then move into the cell. They are hydrating solutions, but they will not drive up the blood pressure because they're not going to stay in the vascular space. Some examples of hypotonic solutions would be a fourth dextrose in water, a half normal saline, 0.3% normal saline, also known as 1/3 normal saline. So when would you use these? If the client has hypertension, renal, or cardiac disease and needs fluid replacement because of nausea, vomiting, burns, hemorrhage. Also, it could be used for dilution when a client has hypernatremia and for cellular dehydration. So if you have a client with vomiting and diarrhea with a blood pressure of 160/98, if you gave that person isotonic solutions, you could cause them to have an increase in their blood pressure and possibly cause an MI. So these are situations where you will use a hypotonic solution. Now let's look at the alerts. We want to watch for cellular edema because this fluid is moving out into the cell and it could cause a fluid volume deficit or a decreased blood pressure. Now let's talk about hypertonic solutions. And what I want to be sure you understand is when you see hypertonic, I want you to think packed with particles. We're going to talk more about that in a minute. Now read in your book with me. Hypertonic solutions are volume expanders. They will draw fluid into the vascular space from the cell. Some examples are listed in your book, D10 and W. 3% normal saline, 5% normal saline. You have TPN. You see albumin listed there. You can add electrolytes or glucose to any isotonic or hypotonic solution and make them hypertonic, right? Remember PID and packed with particles? So if I am giving a client a magnesium sulfate infusion, I am giving them a hypertonic solution, and I had better watch for fluid volume excess and pulmonary edema. Now let's talk about the uses. The client who has hyponatremia or has shifted large amounts of vascular volume into a third space, such as with severe edema, burns, or ascites. A hypertonic solution will return that fluid volume into the vascular space. What are you going to watch for? Watch for fluid volume excess. Clients may need very close monitoring in an ICU setting with frequent monitoring of their blood pressure, their pulse, and their CVP. And also you see a box that provides you with terms that you may see used interchangeably. Isotonic and crystalloid, hypertonic and colloid.